Esophageal endoscopic ultrasound using an endobronchial ultrasound bronchoscope has become an important tool in many bronchoscopy units, mainly as a complement to EUS-b. Education and training for EUS-b is well established through internationally certified training programs, but that is not the case for EUS-b, where structured education programs are still lacking. In this video, we present an educational roadmap for those aiming to venture in EUS-b. Most reported EUS-b procedures are performed as a complement to EUS-b under general anesthesia with laryngeal mask or endotracheal intubation. Nevertheless, EUS-b and EUS-b can also be performed under conscious sedation and spontaneous ventilation with either transnasal or transoral approach. Topical ephedrine solution and lidocaine gel are applied in the nostrils to allow for a more comfortable passage of the endoscope. After external inspection of the nasal cavity, the ultrasound bronchoscope is slowly introduced in the direction of the middle nasal concha, with the ultrasound transducer facing medially. As the scope reaches the middle concha, the bronchoscope is turned 45 degrees counterclockwise. Then, the bronchoscope is gently introduced in order to go through the space between the middle and lower conchae and the nasal septum. After passing the conchae, the bronchoscope is turned 135 degrees clockwise to the usual position and angled anteriorly to enter the oropharynx. Once in the posterior pharyngeal space with the transducer facing anteriorly, the tip can be retroflexed and the larynx visualized. The tip of the scope can then be passed posterior to the arytenoids and slightly angled to the left with gentle pressure. If resistance is faced, the scope can be withdrawn and another attempt on the right side or midline can be tried. To avoid complications, progression and rotation movements must be in a gentle screw-like manner, keeping the scope in neutral position. Also, since the EUS scopes lack the possibility to actively inflate the esophageal lumen, we recommend that suction should be applied intermittently to avoid complete esophageal deflation throughout the procedure. EUS-b relies entirely upon ultrasonic images for localization, and for that matter it is usually more convenient to perform EUS-b with a larger screen width, 8 to 12 cm, and close-up images, 3 to 6 cm screen width, for a better evaluation of the lymph node stations. At the cardia region, the transducer is turned backwards until the abdominal aorta is clearly visualized in its longitudinal diameter. Color Doppler can be used to help visualize flow inside the aortic lumen and celiac trunk and mesenteric artery. At this point, the EUS-b scope is turned clockwise to visualize the spleen, the left kidney and the lag just behind the celiac trunk and mesenteric artery. After seeing the lag, the transducer is brought back to its standard neutral position at the cardia. In front, the left lobe of the liver, diaphragm and heart are clearly visualized. Then scanning proceeds by withdrawing the transducer to the distal and the middle part of the esophagus. The heart is visualized anteriorly, with the left ventricle coming first into focus. At that point the atrioventricular valves and the left atrium with the pulmonary vein close to the esophageal wall. Posteriorly the paraesophageal, station 8, and the lower para-aortic lymph nodes can be seen. Above, in the anterior position, the subcarinal lymph nodes, station 7, are clearly visible. Withdrawing the scope slightly more to the left, air ultrasound artifacts, horizontal A-lines, originated from the proximal wall of the left main bronchus are seen. Further retreating the scope and looking to the left will allow the visualization of the lower paratracheal, station 4L, and deeper aortopulmonary window lymph nodes, station 5, between the pulmonary artery and aorta. At this level, rotating the EUS-b scope to the right, the posterior part of the right paratracheal lymph nodes, station 4R, behind azygos vein, can be found in many cases.